Dear Chairman, ladies and gentlemen, at the beginning I would like to thanks to Professors Skowroński and Oshkinis for that invitation. Thank you very much, and opportunity to talk about very interesting for me, and I hope that for participants, topic of chronic total carotid occlusion. I have nothing to disclose, and what we know about the natural history of carotid CTO. We know that about 15% of all strokes, the large vessel strokes, occurred due to the occlusion, not stenosis. We know that the most dangerous is a first period, is a moment of occlusion and first few days. After that, the patient can stay asymptomatic to the end of his life, but there are a very big group of the patients that after weeks, months or years occurred TIAs or strokes or global brain ischemia as hypoperfusion. So what about the society's guidelines? The vascular societies not recommend reocclusion of chronic occluded carotid artery, but we of course have the choice. We can treat the contralateral carotid, subclavian Still syndrome, vertebral arteries. Of course, we can operate the external carotid artery. And of course, we can try to open surgically or endovascular occluded artery. It's as I said, that is not recommended, but we have the subgroups of the patients with the symptoms after aggressive conservative treatment. What about literature? What about knowledge of the patients after that procedures? With Piotr Głowicki, we tried to found the articles about the endovascular reopening of occluded artery. It's very popular topic, more than 1,200 of articles, but if we use the filters as non-English, non-humans or something like that, we finally chosen only 56 articles and only 8 cohort articles with the good enough data for systematical review. What we know about the patients after that treatment, the group younger than the patients with stenosis, as group is extremely heterogeneous. If we think about the symptoms, mostly symptomatic and mostly with the chronic carotid occlusion. Heterogeneous if we think about anatomical data, the patients with different kind of stumps, with the shapes of stumps, and of course different length, and mostly with the occlusion of cervical part of that artery. If we look at the results, I think that's quite good. Only on that 8 articles, we found only 3.3% of perioperative stroke. The very small numbers of TIAs, very low mortality and not very dangerous complication. If we think about the follow-up, if we compare the patients after conservative treatment and after reocclusion of occluded artery, we see that ipsilateral stroke occurred during the follow-up only in 3.4% of that patients. Of course, the literature, it's very important, such systematical review, but personal experience, I would like to show you own material, not such big, of course, the 27 patients with the chronic carotid occlusion, with the technical success about 52%. Why? Because first we do the primum non nocere, so the safety of the patients was most important for us. So during that procedures occurred the one reversible stroke. The patient was discharged from the hospital without any neurological symptoms. 2 TIAs during the procedure in patients with the difficulty to using the neuroprotection in the first part of that procedure. We do predilation without neuroprotection. and without any severe complications as extravasation or carotid cavernous fistulas or something like that. So I would like to show few examples. Is a long occlusion. You see here the patent after stenting patent internal carotid lumen. This is 1 year follow-up. The very good result. The short occlusion of the carotid artery stenting, and after 5 years, the quite good result with the widening of the lumen of that artery. And you see the most difficult shape of the stump, the blunt stump. But here you see the microcatheter confirmation that we are in the through lumen of the intracranial part of internal carotid artery. And here result just after the stenting. This very narrow, thin lumen of the internal carotid artery. So after 3 months, we performed angiography during the subclavian stenting caused by Still syndrome, and you see that lumen is much bigger. So we never use the intracranial stent as the Asian authors that use sometimes the cardiological stents. And here the conical stump, and just after the reopening of that artery, here is the preoperative CT, and this is a 1 year follow-up. That's the very good result, and 5 years follow-up, and Doppler ultrasound with the good flow in the internal carotid artery. So, but we must talk about the stents and occlusion. Carotid stent, of course, acute stent thrombosis is an absolutely different topic. It's rather procedures like neuroradiological with the thrombectomy of thrombolysis rather than in stenting and PTA. So this is not the topic of my presentation. A few years ago, I found the only photo published by the Borst, partially patent carotid stent with a patent external carotid artery and occlusion of internal carotid artery. And few years later, we found the same, absolutely the same case. So female, 64 years old, with a the big history of atheromatic diseases after coronary intervention, lower limb intervention, and with the stroke. There's a chart show you how big stenosis we had. We started from 75, then 65, then occlusion, and the reocclusion as well, the left carotid artery after intervention and intervention. So see the first is a tight stenosis, stenting, occlusion without flow, and then after PTA and restenting. So we used another stent with the 1 centimeter overlap above the previous stent with a quite good, I think, result. So this is a 1 year follow-up. You see the patent stent. I would like to say again that patients was symptomatic, so not asymptomatic. And so only one conclusion from that presentation, that reopening of occluded artery after stenting is feasible. About safety we can talk if we have some bigger material, but the feasibility, I think that it's as well very important factor. Thank you very much for your attention.